And we're still on dialysis. Okay, so we're gonna get these 2 large bore IV needles. They're gonna be inserted into that graft 3 times a week. And it's gonna hurt, patient's gonna bleed, or they could bleed, have infection. So it's very important that the dialysis nurse, they have a huge responsibility, right? And there's the potential of it clotting, and then it doesn't work at all. Okay? So that's one thing. Think about how tired you would be to go 3 times a week to another place, like a dialysis center, sit in the big chair with all the other dialysis people, have 2 needles poked into your arm and hooked up, and you can't go anywhere for 4 hours. Okay? So that right there would be exhausting. It'd be like commuting, right? So that right there is tiring, okay? But Betty has a fluid restriction, right? Maybe the doc says 1.5 liters per day. So she's got to count water, she's got to count tea, she's got to count anything that has water in it, coffee, her mojito at night, or whatever it is. Okay, so she's restricted to this, and as the days go by, so Tuesday we're filling with fluid, Wednesday, maybe there was a party, so maybe Wednesday is more like this, right? Whatever goes in stays in. It's not going anywhere. The only way she can lose fluid is if she's throwing up, having diarrhea, or sweating a lot. And these people do not sweat a lot. They are dry. Okay? So whatever goes in the tank is staying in the tank until she goes and does this again. Okay? And she's also going to have labs drawn because they have to periodically keep track of her electrolytes, because that's going to determine what kind of dialysate, what kind of fluid they put in that membrane, so they can exchange things and get the potassium normalized. Okay? So that's just to kind of paint a picture. That's why these people are grumpy, and that's why when a patient, they can't eat what they want, so their diet, they're going to have low potassium, right? They can't eat potassium or drink potassium. They have to be careful with phosphorus. So soda is totally out. It's very high in phosphorus. So a lot of the things that make people happy and enjoy life, they can't have.
It's depressing.
Right? Well, I want you to understand, because what then happens is you'll have a patient who's been on dialysis maybe 2 or 3 years. Now they're in the ICU, they're acutely ill, and so we're treating them with something we're going to talk about in a second. Potassium, let's say the potassium is 6.5 and they are positive 3 liters. Okay? And it's very common. They also have diabetes and hypertension and COPD, a little bit of everything. So they're now in the ICU, and so we get them all stabilized, and then they say, I'm done, I'm not doing any more dialysis. And the family goes, oh my God, but no, we want you to live, and Betty, you have to stay with us, we love you so much, please, we'll take you to dialysis. And this is exhausting. And Betty's been doing this for a couple years, and a lot of times it's just for the family. If you have an older patient, or there's some things they want to do, and they got to get their stuff together, But when the patient says, I'm done with dialysis, all we can do is educate and make sure they understand, if you do not have dialysis, the tank will fill up, and the potassium will go up, your heart will stop, you will drown. I don't know what order, okay? But as long as they understand that, then we have to advocate for them and try to discuss with the family and help them understand. Because there will be a point when that patient cannot make that decision. And at least we will know. Now, obviously, we should get it in writing. They should have talked to their family about it way ahead, but most people don't talk about death, okay? So a lot of times when we're younger nurses and we haven't gotten cynical and, and seen all the things that we've seen, you think, no, you can't stop dialysis, you'll die. They know that a lot of times, especially the one that had all the grafts and they were starting with the legs and, it's tough. So just so you understand, there's a lot of psychosocial stuff that also comes along with a renal patient, okay? The uremic frost makes them itchy also, and the high blood pressure, headaches, and they got to take drugs that maybe it makes them impotent or, who knows. Okay, so patient comes in with a high potassium. What's going to happen to this patient if we don't treat it? What kind of dysrhythmia? So something lethal, VTAC, VFib, asystole. This is a common reason for PEA, pulseless electrical activity also. Because of the acid, this patient is super acidotic. Okay, what happens in acidosis in the body? Your cells don't work. Right? Because they're used to this certain environment, and now all of a sudden they're in this hostile acid environment. And they're like, oh my God, we can't work in this kind of environment. Okay? So cells don't work properly. Your blood pressure drops. What happens when your blood pressure drops? What happens to your organs? They don't perfuse, right? So decreased perfusion. This is life right here. Life is perfusion, okay? Decreased perfusion, and then your organs start to die. And once you hit, I think it's the second organ, you add 10% for every organ. So if you're on the ventilator at this point, so that's one organ. If you're unconscious, that's another organ. And if your kidneys don't work, that's the third organ. So you're looking at 30 to 40% mortality at that point. So that's acidosis, no matter what the cause. That's going to happen in acidosis. Okay? So what are we going to do about it? What is your first priority?
To get the potassium down.
If he
Yes.
wants to live.
How do we get the potassium down?
The cocktail.
And the cocktail is not what makes the potassium go down. There's one thing in there. Okay, so we're going to give insulin. How much? And where? And what type? It's regular.
Is it IV?
It's IV. 10 units.
This is if he wants to live, right?
This is if the patient is not a DNR. So here's what happens a lot. Betty's sick of dialysis, so she skipped it. They'll say, oh, I missed my dialysis. They're not going to say I missed it on purpose. They're just, I missed my dialysis. Or Betty went and hung out at the bar. She's like, I'm not going to dialysis, I'm going to the bar. And we say, okay, Betty, let's go. So she perhaps, the container kept filling, and she got to the point where I can't breathe. I am now in heart failure, fluid overload. I got 3 liters of fluid that has nowhere to go. And so that could perhaps have been what brought her in, or she could have collapsed from being acidotic and having a low blood pressure, not enough blood to her brain, and there goes Betty. Okay? But whatever the case, that's what's probably going to bring her in. But it happens a lot. I missed my dialysis. So we're going to give 10 units of regular insulin IV. That is what will bring the potassium down.
But if they're not diabetic, won't they bottom out?
Even if they are diabetic, they'll bottom out. Because we just gave it IV.
So that's where the D50 comes in?
Right, so now we're going to give D50, so 50% dextrose, IV, to counteract the insulin. We didn't need to drop their sugar, we just needed to chase the potassium in the cell, but their sugar is going to drop. So this is where we're talking about therapeutic effect versus side effect. The therapeutic effect is to get the potassium down with the insulin. This is a side effect, the low sugar. And we don't wait for it to drop, we just give the sugar. Okay? And sometimes we'll also give calcium. And it's because of the calcium will follow the potassium. Calcium will drop.
And the KX
And the
is
KX
just
would-
to drop.
Okay, so we'll get to that. So this is the emergency. You have to know this. Please know this. Live it, breathe it, know it. It's not going away. And read it before every med-surg class. And know that it's the insulin that does it. So then you can take that information, and when you're in fourth or when you're in clinic or a PCU even, and you go, patient's on an insulin drip. What's going to happen to their potassium? I'm putting insulin in their IV continuously.
So it's gonna happen to
It's gonna drop.
Their potassium is going to be going into the cells, so that's something you have to monitor. So it's a really important concept, okay? We can also give albuterol breathing treatment,
if they can.
but this, number one, we don't ever think about. So unless you have a really good RT that's thinking about their potassium, probably they're not going to get the albuterol for this, but it will also drop it, but it's going to come right back up. It's a very temporary life-saving measure while we're waiting to get other things going, okay? Now in our class, what would happen is the rapid response nurse would come probably and start managing this, or they would say, we're gonna have an order for the 10 units of insulin. The floor nurses can give this, and if they call in time and all that, but just depending, the patient, depending on the value of the potassium, it may turn into a rapid response situation. Okay,
What was the albuterol for?
it'll lower your potassium.
Potassium.
Mhm.
I just didn't work.
So something to think about. I got a patient that's here with COPD exacerbation, and they're getting albuterol treatments, Q2. Or they're on a continuous albuterol treatment. You got to think about, what's that doing to this? That's why every single patient, you always know their potassium. Because if you had a patient that had a low potassium already, it's 3.0, and now they're getting this continuous albuterol treatment, we're going to have a problem, right? So it's something you would need to question, follow up on. Okay, so this is going to be your gold standard, the 10 units of IV insulin. Albuterol can be given, and then K-exalate. K-exalate. Just like polyethylene something. Can't think of it right now. It has a really long name. So K-exalate, why don't we give that first?
Because if there's no wait.
How do we give it?
Orally.
How long does it take oral things?
30 minutes.
At least 30 minutes. And there's a lot of factors. What kind of digestive system do they have? Had they have bariatric surgery? Do they have an ulcer? Et cetera, et cetera. So this is going to take longer. So you might do this insulin stuff, and then you might chase it with some K-exalate. It gives the side effect of diarrhea, but that does not tell you it's working. So again, therapeutic effect or indication versus side effect. So the therapeutic effect, we're giving it to lower the potassium. So how do you know it's effective?
Potassium goes down.
Because you've lowered the potassium, not because they've had diarrhea. Do you see the difference? I had a patient, the ICU, we like to say, oh, and I'm sorry, all my ER friends, but they get K-exalate in the ER, and then they come up to us in the ICU and we wait for them to poop. Because we know it's going to happen. We're just waiting. We got the bed triple padded. We're like ready to go. And I had a patient like that, and they had 2 or 3 doses of K-exalate, and I thought, oh my God. I was ready for like the hazmat suit, the whole thing, and they didn't poop my whole shift. And I thought, oh my God, what's wrong with this patient? But their potassium went way down. It worked because it binds to it, and it, whatever the physiologic action is that I can't think of right at the moment. But it does lower your potassium, even if you don't have the diarrhea. I've only had one patient like that. Obviously, it was memorable. Well, and then I felt bad. I thought, oh my God, day shift, I'm so sorry. You're gonna have big poops, rivers of poo. So anyway, so the K-exhalate is a slower thing, so we're not gonna be able to, it's not emergent, okay? The best bet is if you have a dialysis catheter, do dialysis. Especially in a patient that's 3 liters positive, they're gonna need dialysis anyway, okay? Any questions or anything to add? Okay.
Well, to end that, the sodium bicarbonate, you don't think of that, or?
You know what, I'm glad you said that. So we don't give bicarb in any of the renal failure situation, or not renal failure situations, acidotic situations right away. And this goes back to more of the blood gas thing, because we want the body to do its normal compensatory thing. So this came up when you have like a respiratory acidosis. Yes, they're acidotic, but you don't want to give bicarb right away, because then the kidneys think, oh cool, we'll chill, we got enough bicarb, you know? Now, in a renal failure patient, this patient probably would get some bicarb because we know their kidneys aren't going to help. But it's not going to be an all the time thing. But yes, so they could get bicarb. We even put people on bicarb drips. Okay?